Welcome to AETCM, the emergency medicine channel. Today we will be discussing a respiratory medicine case. A 66-year-old female was rolled into a ER with complaints of breathlessness since 2 days. Initial 10-second assessment, patient was conscious, oriented and obeying commands. Her airway was patent, there was no secretions, no gurgling, hoarseness or stridor. Breathing, her respiratory rate was 40 per minute and her saturation was 88% in room.
Can you tell causes for tachypnea in ER?
Tachypnea, simple physiological reasons like pain, anxiety, fever can cause tachypnea. Otherwise, any systemic manifestations like pneumonia or ARDS or pulmonary edema, nephrogenic pulmonary edema or cardiogenic.
So physiological and pathological. In pathological, lung-related causes and other causes. Lung-related causes like you told hypoxemia, whatever conditions like pneumonia, COPD, whatever. Other conditions are very important because we are looking at another condition which is not involved in lung. What are the conditions?
Even metabolic conditions like metabolic acidosis, cardiac failure.
Metabolic acidosis is one of the most important causes which can present with tachypnea in ER. Then cardiac conditions like.
Adding to that, what is the change in that tachypnea when it is a metabolic?
Depth of breathing.
Depth of the, very good. So it is actually fast and deep. That's why you call it a Kusumas. That is very important.
So it is a very important finding.
Why it is happening? Because
to compensate for the acidosis.
So it should produce a respiratory alkalosis. To compensate metabolic acidosis.
Yes.
Her respiratory rate was 40 per minute and she was maintaining only 88% saturation in room air. Her chest exertions were increased and she was using her accessory muscles of respiration, like she was using her neck muscles and abdominal muscles for breathing. And
then it will be ideal if you are able to name the muscles.
She was using her sternocleidomastoid and scalene muscles and anterior abdominal muscles also. Intercostal indrawing was also present. So when I auscultated, air entry was reduced on the right side. Moved into circulation. Her heart rate was 120 per minute. Blood pressure was 170 with a map of 80. All peripheral pulses were felt.
Circulation is
CVS and mainly pulse and BP.
Disability, her GCS was E4, E5, M6, pupils were 2.5 mm reactive, exposure, temperature 98 degree Fahrenheit, GRBS was 170. So at this point of time, adjuncts to primary survey, this patient was kept in a proper position and since her saturation was only 88%, oxygen was arranged with a mask and IV cannulas were secured and an ABG was asked for. ABG was showing a pH of 7.328, PO2 of 47, PCO2 72.1, bicarbonate of 21.4 and lactate of 3.6.
Okay, so what is your diagnosis?
So there is a respiratory acidosis along with the metabolic acidosis, lactic acidosis.
So two acidosis are occurring in same patient. Okay, which has got priority now?
Respiratory is there, maybe because of the excess usage of the muscles, lactic acidosis is also set.
Okay. Can hypoxemia itself produce lactic acidosis?
Because of the reduced perfusion to the tissue, reduced oxygenation.
Can produce systemic hypoxemia. That perfusion is still maintained. Okay, that itself can produce lactic acidosis.
Lactate.
We have asked for a bedside chest X-ray and bedside ultrasound was done because right side air entry was reduced. So it was showing a massive pleural effusion of the right side and a collapsed lung, which was seen as a fishtail sign.
So actually the onset, I was not there in the starting. So the onset of breathlessness, what was it?
Onset, we just got a brief history that this breathlessness started 2 days back, sir. Since
onset was not there. So if it is an acute onset breathlessness, what are the things you do suspect?
It can be pulmonary edema, pulmonary embolism, pneumothorax.
Pneumothorax is one of the most important.
That should be the first in emergency.
Should be the first.
Pulmonary edema comes only the third. Usually pneumothorax, commonest pneumothorax. Second is embolism. Third will come as this.
Since we have a lot of cardiac cases, you are seeing most of the cases are pulmonary edema. But if you see general population, pulmonary pneumothorax is one of the most common cause for acute breathlessness in ER.
In that case, which subgroup of patients can develop pneumothorax?
COPD.
One is COPD, the other is any
Marfanoid features.
Yes, then work related. May be difficult for you but important. I studied in Alleppey Medical College. So there few patients came with that. They were smokers but they developed it following swimming. They were collecting muscles. പിന്നെ ചെളി കുത്തുന്ന ഗ്രൂപ്പ് ഉണ്ടായിരുന്നു. So swimming actually they will take a deep breath, then they will swim like that.
So there is a high chance of bulle rupture. Somebody is dying bulle, they go inside, deep inside the water. They take try to take deep breath only during that period.
That period.
Not trained. So they have high in proportion for
developing this subgroup. Then again, of course, what you are told is right.
This may not be there in the books, but these are happening in
practical
peculiar areas. Okay, somebody go in deep into the water, they already have a bulle, they take a deep inspiration, but they are not trained for that. And that suddenly it can rupture.
Yes, sir. Bedside ultrasound was showing massive pleural effusion with a collapsed lung sign.
So what findings will you see in an X-ray chest with the pleural effusion?
X-ray chest we will be depending on the level of pleural effusion. Sir, if it is mild pleural effusion, we will be seeing an the costochrome.
See pleural effusion, white shadow will be there.
Yes,
that's right.
So you have differential diagnosis. One can be pleural effusion, another one can be a mass, another one can be blood. So how do you differentiate a fluid from a mass which is producing white shadow?
Yes, sir.
There is an opacity.
Correct.
Then you have to say
effusion or mass or pneumonia, whatever it is.
Homogeneous or non-homogeneous.
How do you differentiate?
Then you tell the DDs. That is the approach.
X-ray there will be a homogeneous opacity. Mostly if it is if it is not an encysted pleural effusion or something, there will be a blunting of the costophrenic angle and cardiophrenic angle.
So in the beginning stage, blunting
will be there.
Once it
progresses up,
what you are told, there is a peculiar shape
will be there.
Hydropneumothorax, there will be a level, flat line will be there, sir.
Okay.
Then
Girish has told something. Hemothorax. Which situation usually you will get it?
Post trauma we will be
One
getting.
is trauma, the other is
malignant
procedures.
Yes, sir.
Any iatrogenic procedure or trauma or malignancy.
So history is medicine.
Yes, sir.
And mass, suppose there is a mass which also got white shadow in the lungs. Suppose there is pneumonia, that also got white shadow. History is very important, like sir told, whether patient is losing weight, whether the patient is having progressive breathlessness. All these things are important. But in an X-ray, white shadow, how do you differentiate a mass or pneumonia from pleural effusion?
Yes, sir. Pleural effusion, and there can be other symptoms like mediastinal shift. These things will be there.
That is very pleural effusion means an expanding lung. So the mediastinal can
that will compress onto the other side, and there can be features of compression features can be there. There can be tracheal consolidation. Usually there will not be any tracheal shift.
There will not be any shift to opposite side, but same side is possible because of the
collapse, associated collapse.
Then what other finding? What other finding will be there in consolidation? To say it is consolidation.
Air bronchography.
That is very important. Mass, what will be the normal picture?
Actually, it will be well circumscribed usually, and
Sarah told something that is not there.
Lymph nodes can be there.
Just now you told. Consolidation, something that will not be there in the mass, and it will be mostly, it will produce a absorption collapse. It will produce a major bronchus can be blocked and it can produce collapse. What happens to the diaphragm in pleural effusion comparing with the other conditions? Diaphragm, especially in mass, what happens to the diaphragm?
Pushed up.
Mostly diaphragm can be involved because phrenic nerve will be infiltrated by the malignancy. If it is a malignancy, most of the time that phrenic nerve is involved and diaphragm can be elevated. Whereas in pleural effusion, definitely it will never be elevated. It will be flat or compressed. So you have to see all these things. Rib spaces are important, diaphragm is important, the lung area is important, heart is involved, whether the mediastinum shifted. Everything is involved because when you are seeing only X-ray, but we have an advantage that we have an ultrasound. Okay.
In X-ray, when we are taking erect, if at least 300 ml of pleural fluid should be there to tell it as a pleural effusion. Otherwise, when we are taking lateral X-rays, if it is like more than 50 decubitus X-rays, at least 50 ml, if it is there, we can quantitatively tell there is a pleural effusion. Ultrasound can detect minimal amount of effusions.
Ultrasound is more important than X-ray in emergency room. Like this, if it is ultrasound is not available, X-ray is applicable.
So since there was pleural effusion and since she was symptomatic, we have arranged for pleurocentesis. By the time we went to the sample history.
So fever was there for this patient?
No sir, fever was not there. So
weight loss was there?
Yes sir. Sir,
smoking?
No sir, this is a 68-year-old female. Sir.
Females won't smoke?
This female.
Still you have to take it.
Yes sir.
Okay. Because smoking in female is more dangerous than male. They have more prone for a malignancy than males.
And also they will not smoke in public.
Yes, sir.
So you cannot assess.
Difficult.
Okay. Number per day nobody knows. See, if I ask you why you didn't ask hoarseness of voice, what is the importance?
Malignancy, nerve involvement.
Which nerve? Recurrent laryngeal nerve involvement. Very important. So, swallowing, phonation, all these are supported by recurrent laryngeal nerve. So, all these can be affected. So then your question should go up also. History of. That negative history contributes here.
Any other female related organ history you want to know in this patient?
Female organs like ovaries and all, if it is some malignancies and all, or associated symptoms like pancreatitis and all, these can cause.
Girish was telling some important things which requires means that is only window, you open it.
Meek syndrome,
pseudo-Meek syndrome, or any other
malignancy you told. In that case, what finding will you get above the clavicle?
Supraclavicular lymphadenopathy will be there, left side.
Left side is supraclavicular.
Which are the situations you will get supraclavicular lymph nodes?
CA
Systemic,
stomach.
pulmonary, both.
CA stomach.
Yeah.
Virtuous nodes.
Abdominal malignancies, lot of organs can be involved.
TB.
And also bronchodilators. There you can also get axillary.
So we are talking about malignancy.
Malignancy.
TB, what you told is correct. We are not talking about TB.
Then what about lymphoma?
Yes sir.
Lymphadenopathy, pleural effusion. Then I told everything. Sarcoidosis, lymphadenopathy, you can also get here. With the pleural involvement is there. So both group you should do. Infection, then systemic, then local.
Okay.
Yes, sample history. She is a nulliparous woman, 68-year-old female. She has no allergies. She is not on any medications and doesn't have any.
She is more prone for malignancies of uterus, breast, and
breast. Yes. Past history, 2 weeks back she had an abdomen distension and she was taken to an outside hospital and a CT abdomen was done which was showing features of carcinoma of the right ovary. With peritoneal mets and they were planning to do a palliative chemotherapy for this female patient.
Why they are thinking about palliative chemotherapy?
Because CA ovary, it has peritoneal metastasis also.
Metastasis in the same area is already occurred. Now on clinical examination you know that above diaphragm
also involvement.
So this patient may not be salvageable with other type of treatment.
She also had abdominal distension?
Yes sir. With that abdominal distension only she went to that outside hospital 2 weeks back. So
is it come under Meek syndrome or something?
yes, sir, Meek syndrome.
Meek or something else?
Makes a weight loss.
Meek syndrome usually come with ovarian fibromas.
Benign.
Pseudo
Benign.
benign.
Pseudo goes for
Other ovarian conditions.
so it's mostly pseudo Meek syndrome.
Since 2 days.
Pseudo Meek syndrome, to make a like Meek syndrome and pseudo, it's mostly on the right side,
Yes, sir.
on the left side.
This patient is having right side, sir.
Okay,
Right side.
okay.
Right side. This patient had acute onset of breathlessness since 2 days, worsening over time. There is no other history of fever, chest pain, immobilization, cough, or anything, sir. Last meal was 8 hours back.
Okay.
So, systemic examination, there was no pallor, icterus, clubbing was not there, no lymphadenopathy, but bilateral lowering pictumbedal edema was there, sir. There was no dilated neck vein, sir. Going to chest examination.
Dilated neck veins and neck, what it tells you?
This is a case of malignancy, sir. So, there can be associated SVC obstruction or anything obstruction.
In that case, what will be the distribution of edema?
Above the clavicle will there.
That means upper limb and facial.
Head facial.
Yes.
Yes, sir.
That's maybe you even get a engorgement, facial puffiness.
Yes,
Very characteristic. Yeah.
What is Pemberton sign?
When they raise the hands, the face will get engorged. Usually in thyroid.
IVC.
Which one is going to
Sorry,
demonstrate?
SVC.
Yeah.
Go ahead.
Yes, sir.
Okay.
Yes, sir. And then respiratory system examination, inspection, her air entry, chest movements were reduced on the right side. She was using her accessory muscles of respiration. Trachea appeared central. On palpation also trachea was central. Then breath sounds, air and chest movements were reduced on the right side, and auscultation wise right side air entry was reduced, and percussion there was stony dullness on the right side. So.
All in favor of a fluid in the right
Side. The other system.
So, which situation will you do a tidal percussion?
Tidal percussion.
See,
Deep
when
breath.
there is a opacity above the right diaphragm, you don't know whether it is above diaphragm or below diaphragm. So, you will start percussing and the patient is sitting upright. The mid-clavicle line, you will start percussing. You will find out the upper limit of the dullness. Then you will ask the patient to take a deep breath. If the dullness goes down, the diaphragm is
Going down.
pulling it down. That means it is underneath. So, a pathology underneath will push it down or pull it down. But if it is above diaphragm, status quo.
It is in pleural effusion, nothing will happen. There
Nothing
is no
will
change. If it is a liver enlargement, mass in the liver, subdiaphragmatic abscess, all these things will be shifted.
Down.
That is the importance of tidal percussion in pleural effusion.
Other system examination were within normal.
Other system examination within normal means you have to specifically look for other system. In a malignant pleural effusion like this, abdomen you got anywhere there is some finding. Heart, what do you look for?
Pulmonary embolism, features, cardiac, malignant effusion.
Effusion is most important. Brain.
It's very, very important. This is very high chance of multi-system involvement. You cannot say other system. What about abdomen?
Then already there is fluid.
Then how can you say other system involvement is not there?
It is there, already there. So you have to look for other systems
Very important.
specifically for this purpose.
Organomegaly,
Organomegaly has to be looked.
liver mets.
Can be there.
Then any CNS, brain mets.
Brain mets.
Brain mets is highly possible.
Which chance is there?
Lymph
Lymph nodes. Very, very lymphadenopathy can get.
Can spine involved in this patient?
Yes, sir.
Spine is very much
Vertebral
involved.
one.
So that should be detailedly told that there is no spine mets. There is no brain, signs of brain. We cannot know, but we have to tell.
എല്ലാ സിസ്റ്റം വന്നിട്ട് നോ ഒബ്വിയസ്
Involved.
ഇൻവോൾവ്മെൻറ്റ് ക്ലിനിക്കലി സീന്നേ പറയാം കാഷ്വലായിട്ട് പറഞ്ഞാലേ കേട്ടോ ഗുഡ്
then since she was in respiratory distress, we have arranged for a pleural disease and we went ahead with that, sir.
Okay.
So
when will she say the diagnosis?
You can tell
Now you can tell.
now we can
Tell the diagnosis.
This is a 68-year-old female lady, is recently diagnosed case of right side carcinoma ovary, now presented with acute breathlessness and showing features of right side massive pleural effusion is there, sir. X-ray wise there is no midline shift or anything see. Maybe there can be associated, maybe because of the ipsilateral collapse of the lungs, sir.
So, diagnosis that's a summary. Diagnosis right massive pleural effusion, possibly metastatic, with proven ovarian malignancy. Then in respiratory failure or not?
She's in respiratory failure.
In respiratory failure. Which respiratory failure?
Type
1 or 2?
Type 1.
So type 1 is characterized by hypoxemia. Hypoxemia. So type of respiratory failure. And what is the functional status? Able to perform routine activities or only bedridden?
Only bedridden.
Then the diagnosis is complete. Other underlying disorders.
If she has got diabetes,
Hypertension.
No, sir.
hypertension.
That is
Okay.
complete diagnosis.
Yes, sir.
So what do you do for this patient who is having respiratory distress because of right side pleural effusion in emergency room?
Fluorescences should be done, sir. Both diagnostic and therapeutic, sir.
Okay. How much fluid you can remove from this patient?
Maximum 1 liter to 1.5 liter will be removed in the acute setting, sir.
Okay. Why we should not remove more fluid?
More fluid, there is a high risk for re-expansion pulmonary edema because of surfactant dysfunction or because of this negative pressure that is coming in, since we are aspirating more, that will absorb more fluid into the pulmonary system, so that will cause re-expansion pulmonary edema, sir.
If the patient develops, it's a very remote possibility because we are taking care, we may be removing 1 or 1.1 liter. If the patient develops re-expansion pulmonary edema, what do you do?
In acute setting, we should arrange for a positive pressure ventilation, or we can inject back the fluid to the
Whatever
patient's
is available
fluid.
in that syringe should be injected back to the space. Otherwise, patient will collapse. And bypass
Positive pressure ventilation.
Positive pressure ventilation is the best way of treating re-expansion pulmonary edema. How much fluid was removed? What is the color of the fluid? What is the analysis of the fluid? Or you can tell?
This patient ICD was inserted and 1 liter fluid was removed, and the color was it was yellowish red in color, amber. Initially it was a bit hemorrhagic, then it was yellowish red in color, and it was taken for analysis, sir. Pleural fluid analysis for LDH, cytology, proteins were sent, then cholesterol, triglycerides, and these analysis can be done, but initially these all things were sent, sir.
We do ADA?
Yes, sir. ADA to rule out TB, sir.
Okay. So what is your finding in this?
This patient pleural fluid LDH was 1833. Serum LDH was 335, so it was 5.47 when we divide pleural fluid and serum LDH, so it is coming more than 0.6. Then serum pleural fluid protein by serum protein was pleural protein was 4.61 and serum protein was 6.1. So it was coming, when we divide, it is coming around 0.72. So that is more than 0.5. And the pleural fluid LDH is more than 2/3 of the serum LDH. So
it goes in favor of an inflammatory
sedative
problem. Okay. It can be malignancy, it can be an infection,
yes, sir.
something else. But it's an inflammatory condition.
Yes, sir. Then we have sent for the ADA. ADA was only 20, sir.
Okay. So what is the importance of ADA in pleural fluid?
Pleural fluid ADA, if it is more than 40 in units, then it will go in favor of tuberculosis.
So can this patient develop tuberculosis? That is the question. So ADA is negative, so it can be possibly ruled out. But can we think about TB in a malignancy patient?
Immunocompromised
One of the
patient.
most common infection in immunocompromised infection is TB. So always keep in mind, any time this patient can develop TB. Other cells
Cytology was sent. It was showing some malignant atypical cells were present.
It's a malignant effusion.
Yes, sir.
What do you do?
This patient initially we have aspirated her and she was kept in the ICU. Every 2 hourly we used to release the ICD and we will drain at least 200 ml and second hourly 200 ml will be drained and we will be draining so that at 1% if she is having only less than 50 or less than 200 ml drain only for 48 hours, then we will be planning to remove the ICD then only.
Okay. Before removing the ICD, what is the ideal way of treating malignant effusion?
Pleurodesis.
No, that's what will happen to the, it will be refractory or it will immediately respond? That's the question. It will be refractory.
It's not going to improve with your simple drainage. So we have to do pleurodesis.
Pleurodesis, in this, if at all we are having an ICD or pleural catheter, we can insert the talc or the sclerosine. It will cause some fibrosis or inflammation to the pleura and the space will be obliterated.
Okay. Anything else, sir?
No, we presented well and most of the things we covered.
Then in the ICU, when we are admitting her, we should, there is a high risk for DVT and pulmonary embolism and also thromboprophylaxis and given and antibiotics also to prevent infections.
Okay. Okay, sir.
Yeah, right.
Thanks. Thank you.
Okay, good. Thank you.